Hello everyone. Today I am going to teach you about peptic ulcer disease. The term peptic ulcer refers to an ulcer in the lower esophagus, stomach or duodenum, in the jejunum after surgical anastomosis to the stomach or, rarely, in the ileum adjacent to a Meckel's diverticulum. Ulcers in the stomach or duodenum may be acute or chronic. Both penetrate the muscularis mucosae, but the acute ulcer shows no evidence of fibrosis. Duodenal ulcers are 2 to 3 times more common than gastric ulcers. Duodenal ulcers are produced by overproduction of the acid, while the gastric ulcer is usually produced by weakness in the defensive gastric mucosa. Helicobacter pylori is associated with greater than 90% of duodenal ulcers and about 70% of gastric ulcers. Non-steroidal anti-inflammatory drugs reduces prostaglandin productions, which are mucosal protective agents. Smoking, caffeine, and spicy foods increases acid production. Ischemia. Stress. Prolonged steroid intake. Zollinger-Ellison syndrome. Duodenal ulcers usually occurs in the first part of duodenum. The ulcers in the anterior wall usually perforate, leading to peritonitis, while posteriorly placed ulcers erode the gastroduodenal artery, leading to hemorrhage. When the chronic ulcer heals, it can lead to fibrosis and stricture of the duodenum, leading to gastric outlet obstruction. The chances of development of malignancy are negligible in duodenal ulcer. The pain of duodenal ulcer is relieved by food intake. Gastric ulcers are usually large and involve the lesser curvature of the stomach. They can erode into the pancreas, transverse colon, and splenic artery. The chances of development of gastric carcinoma are high in gastric ulcer. The most common presentation is with recurrent abdominal pain that has 3 notable characteristics: localization to the epigastrium, relationship to food, and episodic occurrence. Occasional vomiting occurs in about 40% of ulcer subjects. Persistent daily vomiting suggests gastric outlet obstruction. Occasionally, the only symptoms are anorexia and nausea, or early satiety after meals. In some patients, the ulcer is completely silent, presenting for the first time with anemia from chronic undetected blood loss, as abrupt hematemesis, or as acute perforation. The source of bleeding in the greater curvature and lesser curvature of stomach is left gastroepiploic artery and right gastric artery, respectively. The source of bleeding in posterior duodenal ulcers is gastroduodenal artery. Pancreaticoduodenal artery, a branch of the gastroduodenal artery, supplies mainly the upper and lower duodenum. The upper GI endoscopy is the gold standard investigation. Quick urease test, urea breath test, stool test, and histology and culture are used for detection of H. pylori. Serum gastrin levels to rule out gastronoma. In general measures, cigarette smoking, aspirin, and NSAIDs should be avoided. If H. pylori is positive, then eradication therapy is used. It includes triple or quadruple therapy. Triple therapy includes omeprazole, 20 mg, clarithromycin, 500 mg, amoxicillin, 1 gram, all twice daily. Or omeprazole, 20 mg, clarithromycin, 500 mg, metronidazole, 400 mg, all twice daily. Quadruple therapy, it is given in eradication failure for 14 days. It includes bismuth chelate, 120 mg 4 times daily, metronidazole, 400 mg 3 times daily, tetracycline, 500 mg 4 times daily, proton pump inhibitors, 20 to 40 mg 2 times daily, for 14 days. If H. pylori is negative, then acid suppression therapy is prescribed. PPIs are mainstay of treatment. Surgery in refractory cases. Indications for surgery in peptic ulcer are as follows: perforation, hemorrhage, gastric outflow obstruction. Persistent ulceration, despite adequate medical therapy. Recurrent ulcer following gastric surgery. The operation of choice for a chronic non-healing gastric ulcer is partial gastrectomy, preferably with a Billroth-1 anastomosis, in which the ulcer itself and the ulcer-bearing area of the stomach are resected. For giant duodenal ulcers, partial gastrectomy using a Polya or Billroth-2 reconstruction may be required. Complications of gastric resection or vagotomy are as follows. Dumping. Chemical, bile reflux, gastropathy. Weight loss. Diarrhea and maldigestion. Anemia. Metabolic bone disease. Gastric cancer. Complications of peptic ulcer are as follows. Perforation. Bleeding. Gastric outlet obstruction. Recurrent ulceration. When perforation occurs, the contents of the stomach escape into the peritoneal cavity, leading to peritonitis. This is more common in duodenal than in gastric ulcers and is usually found with ulcers on the anterior wall. Patient usually narrates the history of long-standing PUD or NSAIDs intake. The most striking symptom is sudden, severe pain. Its distribution follows the spread of the gastric contents over the peritoneum. The pain initially develops in the upper abdomen and rapidly becomes generalized. Shoulder tip pain is caused by irritation of the diaphragm. The pain is accompanied by shallow respiration, due to limitation of diaphragmatic movements, and by shock. The abdomen is held immobile and there is generalized board-like rigidity. Vowel sounds are absent and liver dullness to percussion decreases due to the presence of gas under the diaphragm. Chest X-ray shows air under diaphragm in more than 50% cases. CBC shows leukocytosis. Ultrasound abdomen shows free fluid in peritoneal cavity. Serum amylase to rule out pancreatitis. After resuscitation, the acute perforation should be treated surgically, either by simple closure or by conversion of the perforation into a pyloroplasty if it is large. On rare occasions, a Polya partial gastrectomy is required. Following surgery, H. pylori should be treated if present, and NSAIDs should be voided. Peptic ulcer is responsible for 70% of all upper gastrointestinal bleeding. Presentations are hematemesis or melena. Severe bleeding occurs as a result of penetration of duodenal ulcer into gastroduodenal or lesser curvature ulcer into left gastric artery. Pyloric stenosis results from healing of duodenal ulcer, leading to fibrosis and narrowing of its lumen. The presentation is with nausea, vomiting, and abdominal distension. Large quantities of gastric content are often vomited and food eaten 24 hours or more previously may be recognized. A succussion splash may be elicited 4 hours or more after the last meal or drink. Loss of acidic gastric contents leads to alkalosis and dehydration with low serum chloride and potassium and raised serum bicarbonate and urea concentrations. For more videos like these, follow us on YouTube.